It is a great pleasure. I think we can get started to introduce Dr. Martijn Figee. I always try and pronounce that correctly. I never do.
Yeah.
Um, Martijn is a psychiatrist who was trained in the Netherlands, did his residency part of it in the IOP in London. And he really is, I think, a world leader in DBS, using neuromodulation to treat disorders like OCD and Parkinson's and other things. And I think it's, this kind of whole concept of circuit-based treatments is an emerging area. And through his work and the work of others in his group and the larger group here at Sinai, I think Sinai is becoming leaders in DBS and neuromodulation. And it was, I think, a wonderful recruitment to bring you on board. And I think you and your colleagues who will also be presenting here soon really are changing the landscape for some of these very difficult to treat cases of OCD and Parkinson's and other things like that. So I look forward to your talk, and thank you for agreeing to be one of the early speakers in the fall series.
Thank you. It's a pleasure and an honor. So you just mentioned my colleagues, and I want to start with giving a shout out to them. Usually you do that at the end, but I want to stress how important it is to be a center, which we are, the Center for Advanced Circuit Therapeutics, which is primarily based here at Mount Sinai West, which is where I'm now, on the 10th floor. For those who haven't been here, come and visit us. It's really great that Mount Sinai gave us the opportunity to be on a floor with a team of neurologists, neurosurgeons, psychiatrists, psychologists, and researchers. Again, this is usually the last slide, but I want to show it up front also to remind you all how important it is to have this team approach, this multidisciplinary team approach with staff that's actually on this floor, as well as staff across Mount Sinai that we're collaborating with, in order to be able to not only work with, clinically work with very treatment-resistant, severely ill patients that are undergoing surgery, but also, of course, on top of that, doing research to understand their circuit abnormalities and how to manipulate them. And where we start and with which patient is, of course, an important question if you want to do circuit therapy. So I'm going to talk mostly about deep brain stimulation, but eventually this could apply to any form of neuromodulation now or in the future. So where we start often, or a system that's actually amenable, a large brain system that's amenable to neuromodulation, is the cortical basal ganglia circuit, or these are actually different circuits, allowing the integration of daily actions with cognitions and emotions, or reward-based information, to motor and prefrontal cortical regions, which can actually be subdivided into topographically organized levels from dorsal to ventral, with the most dorsal loops or pathways between motor basal ganglia, for instance, the putamen, the subthalamic nucleus, the globus pallidus internal, connecting to motor cortical regions, which is important for movement disorders, which we treat as well at our center, but also for psychiatric disorders, such as obsessive compulsive disorder or Tourette, which is sort of between neurology and psychiatry. And then going a little bit more down, there's the more cognitive or associative circuits between, for example, the caudate and the dorsal lateral prefrontal cortex, important for cognitive control and working memory, and the integration of these systems with actions. And then all the way down to the most ventral loops are of course limbic circuits, limbic or motivational circuits between, for example, the accumbens, the amygdala, and medial and orbital frontal cortical regions, which is relevant for many of the psychiatric conditions that we treat. But of course, there's interaction between these circuits, and there's interactions between these circuits in each patient, whether it's neurological or psychiatric, which is one of the big reasons why we chose to work multidisciplinary and work within psychiatry and neurology. And the way to manipulate or modulate these circuits is, for example, with a non-invasive technique called transcranial magnetic stimulation, which is something we started doing at Mount Sinai around 2 years ago. It's a system that's housed uptown, but we're looking into moving it to West now. And it can be used to modulate motor cortical regions, the SMA or the primary motor cortex. In Parkinson's, it's actually pretty effective. But also in Tourette or in obsessive compulsive disorder. It's even a recently FDA approved treatment for obsessive compulsive disorder. Interestingly, if you target prefrontal cortical regions in Parkinson's, you also treat their depression. And it's not surprising, therefore, that the dorsal lateral prefrontal cortex is also an effective target for depression. And if you go more ventral, you can modulate the medial prefrontal cortex or even the orbital frontal cortex, which allows you to change these limbic circuits, which is an effective treatment for OCD, but also for depression. Now, if you want to get at these more deeper structures and also in a more lasting way, because TMS is a treatment that you can apply for a couple of weeks. But if it doesn't work after the application, it's hard to continue applying it. Patient has to come to the office. So if you want to go at these deeper structures, you can actually implant a lead or 2 leads, usually going to, for example, motor structures like the subthalamic nucleus or the GPI for Parkinson's, or the more limbic loops, like the interior limb of the internal capsule, the alic or the ventral alic, which connects these limbic basal ganglia with medial prefrontal cortical regions. And it's actually the target of choice here in Mount Sinai for obsessive compulsive disorder. The target of choice for depression in our center is the subcallosal cingulate, which is not exactly within these loops, but at least it's connected to the ventral striatum and the amygdala, but it's also connected to a more elaborate mood control circuit involving various cortical regions. And of course, that's the target that Helen Mayberg has examined for years and now brought to Mount Sinai for depression. We started targeting the ventral alic by actually targeting the accumbens, which, as you can see, is a little below. So the ventral alic is actually this bundle of white matter fibers connecting the accumbens with medial prefrontal regions and thalamus and brainstem. And although we and other groups started targeting the accumbens because we knew it was an important structure for reward, and also we found abnormalities in obsessive compulsive disorder, we ended up going and activate the contacts, because each lead has 4 contacts, that were always more in the ventral interior capsule. This is actually something that has happened over time in DBS in general, especially DBS in psychiatry. We used to target gray matter structures, but only to find out over time that actually most effectively treatment was usually in white matter fibers. Again, making the argument that it's more of a network intervention. So this is the way we used to do it. It's actually an atlas-based coordinate that you then translate onto the patient's brain scan, and then you can actually place the lead specifically in this coordinate. But it's sort of a one-size-fits-all because it's atlas and coordinate based. Nevertheless, working pretty good. So this is these are the most recent results from my previous Amsterdam group, which I'm still sort of involved in. And as you can see, it works. These are, again, severely ill, completely refractory patients, and at least half of them responds, even though it's sort of a one-size-fits-all intervention. It also works for depression and anxiety, as you can see by the drop in Hamilton A and Hamilton D scores, which is one of the reasons we also tried this same target in a group of depressed patients with also very good results. And these are all open results in 70 patients, but we also have placebo-controlled or sham stimulation-controlled results showing a significant difference between real and sham stimulation. And this is one of the reasons why for OCD now deep brain stimulation is an FDA approved, although still also experimental treatment. However, 50% is okay, but it still leaves room for opportunity, which is what I and our group want to try and achieve here at Mount Sinai. One of the things we found in our Amsterdam patients is, and these are 12 patients using individualized diffusion tangent imaging, is two things. One thing you can see in these 12 patients that despite the fact that the atlas-based or the MR-based coordinate is pretty similar in each patient, if you overlay that with their tractography, it's really different in each patient. So the way these bundles, these limbic bundles that we try to target course in each patient is highly variable. And in these 12 patients, we actually found that that's not a trivial thing. It's important because we found that like the top patients that have a larger Y-box decrease, Y-box is of course the most prominent OCD outcome, the more likely they were in one versus the other ALIC track. In our hands, this was a track that was seeded from the ventral tegmental area versus one that was more medial coming from the anterior thalamus. At the same time, other European centers were exploring like a similar question, but they didn't have the luxury of using individualized tractography, which needs to be of high quality. So they used normative, like healthy control-based tractography data overlaid with the patient's implants. And this is work from Andreas Horn, who's a prominent DBS neuroscientist, who was trained in one of the other circuit therapeutic centers here at Harvard and now works in Berlin. And this is results from a meta-analysis in 33 ventral alic OCD patients across different centers in Madrid, Berlin, Grenoble. And as you can see, there's actually a wide variety of most of the basal ganglia, cortical loops that I showed before that are actually connected to the stimulated contacts from all of these patients grouped together. You can see some amygdala fibers going to the prefrontal regions, some motor fibers and fibers going to the brainstem. However, if you only plot the ones that had a good response, or actually correlate them with the amount of response, you'll find that these therapeutic fibers are more alike what we showed in our Amsterdam sample, meaning fibers going from the brainstem and the thalamus to these prefrontal regions. The Mount Sinai patients, I think we've done 14 so far. This is results from 10 of them are actually along the same lines in terms of response. Again, it's a average 44% decrease in Y-box, which is pretty good for these refractory patients. And it's also significant. And again, this is mostly based on coordinate-based targeting. It's a very decent result. And if we tried to overlay, and this is work by Andrew Smith, who's following a physician research track working with us. If you overlay that to the MEDA track from the European sample, you can see that the leads from our patients are sometimes in this track, sometimes outside of it. In fact, there's also a blue track going to the amygdala that I depicted before. That was actually negatively correlated to response. So it seems to matter where you are. Again, this is based on normative data. And if you correlate like the response, like the Y-box improvement in our Mount Sinai patients, again, it seems to overlap with these fibers going from the brainstem and the thalamus to prefrontal regions. So the more, the higher their fiber score, the more overlap with this track, and the higher their response on the Y-box. You can also see a few patients that do have a good response, but are not in this track. When we modeled this, this was actually more towards the dorsal pathways. So there seems to be individual variety, which is important because that might be the key to further improving this treatment. I want to have you look at a poor responder. And this is a patient, I'm going to show you a video. By the way, I'm going to show several videos, of course, in agreement with each individual, because I think it's important for you all to see like the effects of this method in actual patients. Is one of the reasons why it's so inspiring to do this work and why it's so interesting to look at these tracks, because you can actually see the immediate effects of this method. So this was a patient, this was one of the poor responders of the Mount Sinai cohort. His compulsions are religious, so it's literally taking him hours to say his prayer. And he's also engaged in all sorts of hand washing rituals. And as you can see, we did actually, with his stimulation, as we applied it, trial and error, we did actually engage these amygdala fibers, which might, according to the meta-analysis, actually be negatively correlated with response. but we didn't engage these brainstem prefrontal or thalamic fibers. And this is the patient being engaged in his compulsive ritual. I have to make sure that I'm actually also sharing sound. Yeah, I do.
I thought of something in the middle.
When he's interrupted, he has to start all over again. So we modeled a different setting, activating one more dorsal contact. And now we did actually get these fibers that are associated with therapeutic effects. And right after we made this change as modeled, you can see the result. Now all of a sudden you can hear him actually saying his prayer much faster, like 3 times faster, and also very fluent. So you can probably understand now why it's so inspiring, because you can see these immediate effects. And this was actually one of the good responders, which I depicted here. And this is one of the most recent patients where we actually applied tractography informed targeting. So Ki-Sung and I work with Dr. Coppel, our neurosurgeon, to actually leave the method of coordinate-based or atlas-based targeting, but really targeting at these specific tracks, which, as far as I know, only a few centers are starting to do. But if you do so, at least so far, you can see very immediate effects. So this is a patient with all sorts of mental compulsive rituals. It's very hard to engage him into an interview because he's constantly preoccupied with these rituals. He's also moving his body, and he's constantly counting. And this was one of the patients that we actually were able to implant like right in this therapeutic tract, as you can see here. And when we activated his neurostimulator, we saw an immediate response with the patient becoming more engaged and actually forgetting about most of his compulsive rituals. And up till today, we're now 1 year after surgery, he's still doing very well. Of course, I'm also hugely inspired by Helen Mayberg's results so far, which is basically this method. So in her patients, in her Emory cohorts, working with her group, some of them who are now here, she was actually able to show an enormous improvement of outcome using this method, where the efficacy or the effects of subcallosal DBS improved from 40 to around 70 to now over 80% using tractography-based targeting and programming. And so this means that there's definitely room for improvement, and that we shouldn't be happy with the 50% that we're getting now. Looking at the ALIC, it's interesting to learn from tracer studies and human tractography studies, for example, those from Susan Haber's group, depicted here, to see that the ALIC is actually projecting to different cortical regions. So, could we precise our targeting by looking at these cortical projections in each patient? So you see the ALIC, And you can actually see that the lateral parts of the internal capsule are projecting to the dorsal lateral prefrontal cortex and the ventral lateral prefrontal cortex. The most ventral part is going to the ventral medial and OFC, and then the more medial parts of the ALIC are projecting to the dorsal ACC and the dorsal medial prefrontal cortex. And Ki-Sung Choi, our neuroimager, was actually able to show in our patients, in the Mount Sinai patients, if you average their tractography maps to the stimulated regions, the same regions came up in our patients, meaning that, the way we use DBS now in these patients, we're also modulating these various cortical projections of the ALIC. And in fact, we could see that it's important for the response. You can see here plotted the number of streamlines from the region where we end up stimulating in each patient to these cortical projections. And you see that responders sort of share projections to all of these cortical regions. However, the non-responders seem to have overlap to some of these cortical projections, for example, those most ventral, but not so much to dorsal lateral or ventral lateral. They seem to lack those streamlines, at least less than the responders. And it might even be, like was also showed in this meta-analysis, that there are negative tracks which may delay or even negatively influence the outcome. In our hands, this ventral medial prefrontal track, which was actually correlated with a negative response. So is there a way to selectively stimulate each of these pathways in each patient? And yes, there is. There are now available, commercially available directional leads with which you can actually selectively and directionally stimulate in the lateral and medial directions, at least for the middle two contacts. And Ki-Sung was able to show with these electric field models that they are actually applicable to modulating these different cortical regions. So we found when we model it that the lateral segments are actually able to connect to dorsal lateral prefrontal cortex and ventral lateral prefrontal cortex as predicted. And then the medial ones would take you to dorsal medial and dorsal ACC, whereas the lowest contact would go to ventral medial prefrontal cortex and orbital frontal cortex. So that's all fine, but which are the ones that are optimal for OCD, and how can we use these for individual patients? This is a patient with like really outspoken motor compulsions. It can take him hours to walk through the door because it doesn't feel right. He needs to go back and forth, as you can see here, on the day of his surgery. And we imagined that ventral lateral prefrontal cortical stimulation might really help this patient, because my previous work showed that ALIC DBS is actually able to normalize VLPFC activation associated to motor inhibitory control in patients with OCD. So we modeled these fibers going to the ventral lateral prefrontal cortex, which again would be one of the segmental contacts. And we were able to show with this very selective segmented setting that he was able to walk fluently again. This is a patient where we applied this method, so selective stimulation, intraoperatively. Dolu is one of our researchers that greatly helped me set up video and sound, and also like sliders with which we can selectively measure different symptomatic outcomes, to intraoperative stimulation. You can see the patient here with a stereotactic frame that the surgeon needs to steer the implantation to the right target. This is the patient before we activate the system. And you can see right after activating the system, he starts to smile, especially with this first ventral medial orbital frontal connection. It's actually also sort of a unilateral smile, which is interesting. This is right-sided stimulation. And it's actually prescribed in the literature before, probably connected to like an amygdala motor fiber. And you can also see, like when we plotted his symptom responses, like a huge increase in specifically motivation, not so much mood, which aligns to like the function of these motivational limbic fibers, as well as a selective improvement with this lateral, presumably ventrolateral prefrontal cortex contact. So this is very promising that you can already see intraoperatively the sort of use case of very selective stim. So now we have to find out what is actually the right sort of stimulation map for all of our patients as well as individual patients. So this is a study that we're about to run here at Mount Sinai, where we are individually targeting 20 patients using tractography, as shown before. Then every 2 months, we're measuring their outcomes as well as behavioral tasks that map onto different circuits, which I will show you in a minute. And then after 1 year, we'll pick apart responders from non-responders and try to differentiate their stimulated targets or tracks. Working with Chausi and Vincenzo from the computational lab, we've designed a battery of tasks that actually tap into these different circuits for motor control, for reward, positive and negative reward prediction, and for reversal learning and flexible control. And so each 2 months, we're trying to map outcomes with these tasks onto selective stim, which is great for exploring like individual targets for each patient, but it also gives you a nice, almost Ardocian map of task outcomes associated to stimulation in these different circuits. Alison Waters has a great EEG tool, which we also use in this study, where she was actually able to show that with selective stim, she was able to demonstrate also selective EEG signatures in response to the stimulation measured on the scalp. So you can see here these different signatures, which is something that we're going to use also in these 20 OCD patients. So what about motor DBS? Is that really motor? So DBS for Parkinson's, of course, is targeted at these typical motor circuits, for example, the subthalamic nucleus or the globus pallidus internus, connecting to motor cortical regions. But we know that these circuits, of course, are interconnected with the more associative and also limbic circuits. And we also know these are results from Mount Sinai Parkinson's patients, that we measured during their deep brain stimulation screening. So these are regular medication-treated Parkinson's patients. So we know from these patients that their motor symptoms are dopamine dependent. Of course, Parkinson's is in part dopamine depletion. So if you take these patients off of their dopamine substitution therapy, you'll see an enormous increase in their motor symptoms, for example, tremor and rigidity. That's something we knew. What we didn't know was whether their non-motor symptoms, like their mood or symptoms that are prevalent in Parkinson's, like compulsivity, anxiety, or apathy, are also dopamine dependent. And indeed, some of them are. Apathy most prominently, which is lack of motivation. If you take patients off of their dopaminergic medication, you see their amotivational, their apathy scores increase. This was measured with the Stark-Steen apathy scale, the SES. We also saw significant differences, but now the other way around, for compulsivity and impulsivity. So things like hypersexuality, compulsive eating, gambling, spending, these are measured with a scale called the QIP. And there you see the reverse pattern. So more compulsivity and more impulsivity with patients on dopaminergic medication. There was not a significant difference between these two states for depression and anxiety. So far it seems that mostly apathy and compulsivity are dopaminergic dependent behaviors which are not traditionally addressed with DBS because it's mostly focused at these motor parts of the subthalamic nucleus. However, that might be very important. That might be actually important to target these non-motor circuits, because what we see, and this is actually also something that's seen in meta-analysis across the world, that many patients with subthalamic DBS and Parkinson's, despite having a very good motor outcome, still suffer from apathy or lack of motivation. In our Mount Sinai cohort, actually half of the patients score above the cutoff of apathy. So those patients typically tell their neurologist that they don't feel that much improved, even though their motor scores show that they have beautifully improved. But they don't seem to be able to motivate themselves to get up from their chairs and move, despite the fact that their motor symptoms have greatly improved. This is a patient with apathy and a high score on the apathy scale that actually reversed after stimulating a different contact. You can see that also his motor scores improve a little bit, at least he's less dyskinetic, but definitely he looks much more alive and less apathetic, and this is also something he reported again immediately after we adjusted his stimulation settings. So this shows that contrary to like what is currently believed mostly in the field of neurology, this sort of motor DBS can actually also be used to address these non-motor symptoms. And that makes sense because if you look at the projections of the subthalamic target modeled in our Parkinson's patients, you can actually see that where we stimulate, again, this is usually targeted at the dorsal STN for motor circuits and motor symptoms. There's also definitely connections to these associative and limbic regions. And actually, when we compare patients with apathy to those with no apathy after DBS, this is work with Lucia Bederson, who's a medical student doing research with us. We can show that the apathetic patients had actually missing engagement of mostly these limbic projections, which is an interesting finding. I mean, most in the field tend to believe, again, that like apathy is not something that is amenable to DBS. And if so, it's often believed that it's a side effect. But here we show that it's actually something that's being missed in current stimulation methods. Allison again was able to find also an effective, like sort of functional readout of this limbic stimulation. So here, this is one patient using the same method that we also use for OCD and actually also for depression. When we stimulate the ventral contact, we can see engagement of these prefrontal limbic pathways. So this is useful for studying how to best actually target these limbic prefrontal regions if we want to reverse apathy, which is something that we're about to do in a study where in existing Mount Sinai patients, we are first further mapping these apathy maps by comparing patients with and without apathy after motor DBS. And then we use a second cohort of prospective patients, wait and see if they do or don't develop apathy. If they do, we're trying to adjust their stimulation setting towards getting the non-apathy map of our first cohort. And then, of course, see if they improve in terms of motivation and apathy scores, and not at the cost, hopefully, of their motor outcomes. This is one patient where we tried this successfully. So the patient had apathy and, as expected, was relatively lacking limbic connections. Did have good motor and some associative connections, but not so much those limbic prefrontal connections. And when we modeled a setting which would give us the limbic connections modeled onto our group maps that I just showed you, and adjusted the stimulation accordingly, we were able to decrease this patient's apathy scores from 20 to 12 without actually adverse events, showing that it's actually a very promising technique that, of course, we have to further back up with a larger number of patients to base our maps on. That brings me to the end of what I wanted to share with you today, ending again with this group of great people to work with. We have different other projects in the pipeline. Alison Waters, for example, is trying to decipher the brain circuits underlying urges to tic and compulsions, which may also be relevant for neuromodulation of addiction. Of course, we're having very promising ongoing work with Helen's subcallosal patients. I'm very impressed so far with the first 2 patients that we implanted here at Mount Sinai. It seems to be very precise and very immediate also in terms of their outcomes, which is, again, very inspirational for me to try to achieve also in the OCD and Parkinson's patients. We have very interesting work with Xiaoxi's lab and Alex using voltammetry, where we're able to intraoperatively measure dopamine and serotonin and noradrenaline, which will be hugely interesting also for like a biomarker of selective stim in our OCD patients. We're working with Stephen Heiss, who is an expert in facial expression and speech analysis, which we can actually apply to these videos that I showed you to maybe pick up more subtle changes than we're able to catch with our traditional skills. And then I have a very interesting project with people from Hopkins where we try to target a substantia nigra sensory cortex circuit for patients with schizophrenia with very promising results in the first patient. So with that, I would like to really end and welcome questions and discussions. Thank you.
Thank you, Martijn. So as a reminder, use the Q&A function to ask questions. That was to everybody but you, Martijn. But if you want to read them, or I can read them to you. Do you see them? Shari, the first question. It's a question about
a patient recently mentioned transcranial direct current stimulation, TDCS. I wasn't able to find much info about it. Would you comment on it? It was endorsed by a member of our Sinai faculty. We do use, I mean, I know the addiction group uses transcranial direct current stimulation, which is, it's a little different, but comparable to transcranial magnetic stimulation. It has the advantage of being more flexible. You can also apply it even in the home setting, which is one of the reasons it's being used for addiction research. It's not something we're using so far in our neuromodulation center. Yeah, for various reasons, but we use transcranial magnetic stimulation, which seems to be a little bit more precise in terms of targeting than TDCS. But it has shown some promising results also in OCD and depression.
Thank you.
Then is another question. You mentioned the possibility of hitting negative tracks that negatively correlate with positive outcomes. Did any of these patients actually develop worse OCD symptoms after the abuse? That's an interesting question. So far, we either see no or little response, like below the 35% responder threshold. Not particularly aversive or negative outcomes. So I think I should reframe that. Like the one patient that I show you with the compulsive prayer, we did hit his so-called negative track, which was supposedly this amygdala fugal tract. And I must say that he did report some anxiolytic effects with this kind of stimulation. It just didn't affect his OCD. So I'm not sure even if these are really negative tracks, but maybe they just target other symptom constellations, which may or may not be relevant for this particular patient. I must say that side effects are actually pretty rare with deep brain stimulation, and if we see them, it's actually very easy to reverse them by changing or lowering the stimulation. In fact, many patients are able to stop their medication once successfully treated with deep brain stimulation, which greatly contributes to like the experience of less side effects also in the Parkinson's patients.
That was a fantastic talk and really exciting. I wish I was working in that space, but it's too late. Yeah, I think it's really elegant work. It's nice to see the integration of MRI information and tractography. That's really an amazing step forward. If anybody has any last question, I'm sure Martijn will be happy to take it. Otherwise, we'll see you in a couple of weeks again. Well, we'll see you actually in November. We're going to pause this seminar series for October. Yeah. Okay. thank you all. Thank you, Martijn.
You're welcome.
It's a great talk, and we really
Thank you.
appreciate it. And thank you all the participants.
Okay, thank you. Bye-bye.